Hello everyone and welcome to our module on carbon dioxide. Carbon dioxide is produced by cellular metabolism, and I talk about this at length in many of the videos in the biochemistry section. But once carbon dioxide is produced, it has to be transported to the lungs so it can be excreted, and there are three mechanisms by which carbon dioxide is transported to the lungs. A small amount is dissolved, an even smaller amount is bound to hemoglobin, and most of it is converted into bicarbonate. Let's talk about the dissolved carbon dioxide first. When you have a gas in equilibrium with a liquid like our plasma, a certain amount of that gas will dissolve in the liquid, and the amount that dissolves in the liquid is determined by Henry's law, which you probably studied in a college chemistry class. And Henry's law says that the amount of dissolved carbon dioxide in the liquid is equal to the partial pressure of carbon dioxide times the solubility. And in human plasma, this works out to a very small amount of the total blood carbon dioxide, about 5%. The way that most of the carbon dioxide is transported through our body is in the form of bicarbonate. If you look at the bottom of the screen, anytime CO2 is produced, it can react with water to form carbonic acid, which can then go on to form bicarbonate and a proton. And it is in the form of bicarbonate that most of the carbon dioxide our cells produce is found in the plasma. Bicarbonate is a carrier of carbon dioxide, and in order to synthesize it, you need an enzyme called carbonic anhydrase. This enzyme will convert the CO2 into bicarbonate, and we have lots of carbonic anhydrase in our red cells in order to convert the carbon dioxide into bicarb. So let's take a look at this slide, which gives the big picture of how our body uses bicarbonate to transport carbon dioxide. In our tissues, oxygen is consumed for metabolism and carbon dioxide is produced, and that carbon dioxide passively diffuses into red cells. Once it gets inside red cells convert it to bicarbonate, which is then transported out in the venous blood. So if you take a sample of venous blood from a patient, you will find lots of bicarbonate. All that bicarbonate came from the red cells, and the red cells use the carbon dioxide from our tissues in order to produce it. The bicarbonate moves through our veins to the lungs, where it's converted back into carbon dioxide, and then that is exhaled. So what we've done here is taken carbon dioxide from our tissues and exhaled it from the lungs, but in order to transport it to the lungs, we've converted it into bicarbonate. And that's what happens to most of the carbon dioxide in our body. It gets converted into bicarbonate. So now let's look a little more closely about how red cells handle carbon dioxide and bicarbonate. As I told you on the last slide, carbon dioxide can passively diffuse into red cells, and red cells have carbonic anhydrase, which can convert the carbon dioxide into bicarbonate. What's going to happen is the bicarbonate is going to leave the red cells for the plasma, and the H+ is going to stay behind. We'll talk more about how the red cell handles this in a minute. But because bicarbonate has a negative charge, when it leaves the cell, something with a negative charge must come back inside the cell, and that something is chloride. Chloride comes into red cells in exchange for bicarbonate in order to maintain electrical neutrality. This phenomenon is called the chloride shift, and for this reason, in the venous blood, you find lots of chloride in red cells. The reason you find that is because those red cells have pulled in the chloride in exchange for the bicarbonate that they're putting into the venous side. Any red blood cells in the venous blood are going to have lots of chloride for this reason. So now that we talked about how the red cell will get rid of bicarbonate in exchange for chloride, what about the protons that are generated? All those protons, if they were allowed to float around inside the red cell, could cause a dangerous fall in the pH, which could be deadly to the red cell. But this does not occur because deoxyhemoglobin is a very good buffer for protons. It binds to the protons and prevents the pH from becoming very low. And this is a very smart system when you think about it, because anytime there's lots of carbon dioxide, that means there's lots of metabolism going on, and that means there will also be lots of deoxyhemoglobin. So as the oxygen is pulled from the heme moieties in hemoglobin, this is a heme moiety right here, as the oxygen is pulled from this, it creates deoxyhemoglobin, which can then bind a proton and prevent the pH inside the red cells from getting dangerously low. So once again, here's the big picture of what's going on. We've got tissues where oxygen is being consumed and carbon dioxide is being produced. The carbon dioxide diffuses into red cells, which converts it into bicarb, and then the bicarb goes out into the venous blood in exchange for chloride. Metabolism by cells in our tissues also makes lots of deoxyhemoglobin because the oxygen is consumed, and that deoxyhemoglobin is a buffer for red cell protons, and that prevents the pH from dropping. So if we go back to this slide, we've talked about the 5% of carbon dioxide that's dissolved in our plasma. We've talked about the 90% or so that is carried as bicarbonate. Now we're going to talk about the small amount of carbon dioxide that's bound to hemoglobin. When carbon dioxide binds to hemoglobin, it forms a structure known as carbaminohemoglobin. This occurs because of carbon dioxide binding to hemoglobin at a different site from oxygen. Carbon dioxide does not bind to the iron in the heme moiety like oxygen does. And once carbon dioxide binds, it alters the affinity of hemoglobin for oxygen. When more carbon dioxide is bound to hemoglobin, hemoglobin releases more oxygen. Or stated another way, carbon dioxide binding decreases the affinity of hemoglobin for oxygen. And if you think about it, this is very logical. Anytime there's lots of carbon dioxide around, that means there's lots of metabolism occurring, and therefore the body wants hemoglobin to release oxygen, and that's exactly what it does. It releases oxygen so it can be used by cells for metabolism. Carbon dioxide also leads to more release of oxygen from hemoglobin through another mechanism called the Bohr effect. As we talked about earlier, anytime carbon dioxide is produced by metabolism, this leads to the generation of protons inside red blood cells through this equation shown here. What this means is that an increase in protons and a decrease in pH are both indicators of metabolism. Anytime there's more protons or a lower pH, that means metabolism is going on. And therefore, we have evolved such that these things, a high H plus or a low pH, trigger the release of oxygen by hemoglobin. This is all very logical. When there's cellular metabolism, there's more CO2 that raises the proton count and lowers the pH, and that triggers hemoglobin to release oxygen so it can be used for metabolism. And this phenomenon is known as the Bohr effect. The way the Bohr effect works is that deoxyhemoglobin has a high affinity for protons, as we talked about earlier. This is what buffers the pH inside of red cells. When protons bind to hemoglobin, this is going to mean that the red cell is in an area with relatively low oxygen and relatively high carbon dioxide because there's lots of protons around. Therefore, the binding of hemoglobin to a proton converts hemoglobin to the taut form, which is the formation of hemoglobin that releases oxygen. I talk about this in detail in the video on hemoglobin, but the taut form, when you have more of that around, it shifts the oxygen dissociation curve to the right. The net result is that because of the Bohr effect and because of all these protons binding to hemoglobin, hemoglobin releases more oxygen, which is useful for metabolism. And here's a hemoglobin oxygen dissociation curve. I talk about these in detail in the video on hemoglobin, but what the Bohr effect does is shift the curve from the baseline blue state to the dashed red line. That's what happens anytime there's lots of protons around, meaning a low pH, or lots of carbon dioxide. This is called a right shift of the oxygen dissociation hemoglobin curve, and it means that more oxygen is offloaded for any given PO2. So for example, imagine that we're right here in the tissues and we have a PO2 of 40. If we're operating on the baseline curve, hemoglobin is going to be about 75% saturated. But because of the Bohr effect, hemoglobin will shift to the red curve, and then at a PO2 of 40 in the tissues will be about 50% saturated. This means that hemoglobin has let go or offloaded more oxygen, and that's useful for cellular metabolism. So when there's lots of carbon dioxide around, that leads to the generation of protons inside of red cells, and that shifts the oxygen hemoglobin dissociation curve to the right. This is known as the Bohr effect. Well, the Haldane effect is essentially the opposite of the Bohr effect. The Haldane effect describes how when oxygen binds to hemoglobin, this alters the affinity of hemoglobin for carbon dioxide. So because of the Haldane effect, when there's a low oxygen environment like we have in our tissues, hemoglobin binds more carbon dioxide. That's wonderful. In our tissues, there's lots of carbon dioxide, and we want to bind it and transport it out of the tissues to the lungs. On the other hand, when we get to our lungs and there's lots of oxygen around, because of the Haldane effect, hemoglobin will bind less carbon dioxide. And this is also wonderful because this causes hemoglobin to release carbon dioxide in the lungs so that it can be excreted from the body. So the Haldane effect says that deoxyhemoglobin binds more carbon dioxide, and this allows more carbon dioxide to be loaded in areas where there's lots of oxygen consumption, like the tissues. In the tissues, lots of oxygen is being consumed for metabolism, so there's a lot of deoxyhemoglobin around, and that can bind more carbon dioxide because of the Haldane effect. In contrast, when you get to the lungs and the O2 level is very high, then there won't be much deoxyhemoglobin around, and therefore CO2 will be unloaded so you can blow it out of your lungs. The graph shown on this slide shows the partial pressure of carbon dioxide on the x-axis and the hemoglobin carbon dioxide content on the y. And what you can see is that the curve is not fixed. Just like the oxygen hemoglobin dissociation curve can shift to the right or left, so too can the carbon dioxide hemoglobin dissociation curve. The curve for hemoglobin carbon dioxide binding is a straight line as shown here, and when we're in the tissues and we have a low concentration of oxygen, we operate along the blue line. When we're in the lungs and we have a high concentration of oxygen, we operate along the purple line. So the partial pressure of carbon dioxide in our tissues is somewhere around 45, so let's make this 45 right here. And if we're in our tissues, we're going to bind up to this percentage of hemoglobin on the y-axis, so that's a point right here. And let's just, for argument's sake, call that 50% saturated with carbon dioxide. But then when we get to the lungs, we're going to shift over to here. And now when we get to the lungs, even if the partial pressure of carbon dioxide does not change, we will now be at this point here, which is over here. Let's call it 25%. So the point is, in the lungs, there's much less carbon dioxide binding compared to tissues, which is great for offloading carbon dioxide. And then the tissues, there's much more hemoglobin binding of carbon dioxide, which is great for pulling carbon dioxide from the tissues so it can be transported back to the lungs. Here's a slide summarizing some of the important differences in terms of oxygen and carbon dioxide in the tissues versus the lungs. In the tissues, the oxygen level is relatively low because of consumption, and the CO2 level is relatively high because of metabolism. There's a high content of protons in the tissues and therefore a low pH. And these circumstances here all favor the unloading of oxygen through the Bohr effect, and they favor the loading up of hemoglobin with carbon dioxide via the Haldane effect. In the lungs, the O2 content is high because you're breathing in air, and the CO2 content is low because you're exhaling. This leads to a low content of protons and therefore a high pH, and these circumstances favor oxygen loading via the Bohr effect and favor CO2 unloading via the Haldane effect. So here's a table summarizing many of the important parameters associated with carbon dioxide transport in the blood. On the left side of the table, I have parameters related to blood that is leaving the lungs and filling the arteries. And on the right side, I have a column with parameters of blood that is leaving the tissues and filling the veins. If we draw two lungs here, what you have is blood that is coming into the lungs from the venous system. And the concentration of CO2 here is going to be basically the same as the concentration when it leaves the tissues. So venous blood represents carbon dioxide content of blood after it leaves tissues and before it gets to the lungs. On the other side of the lungs, we have blood that flows into the pulmonary veins in the left atrium and eventually goes to the arteries. So if you take a sample of arterial blood, you're sampling the blood leaving the lungs, and that's going to have a CO2 concentration similar to whatever is achieved after blood has passed through the lungs and CO2 has been excreted. So back to this table, in the arterial side of the body, the normal PaO2 is around 90 to 100, a normal PCO2 is about 40, a normal bicarb is about 24, and a normal pH is 7.4. In the arteries, the amount of deoxyhemoglobin is very low. That's because most hemoglobin is saturated with a molecule of oxygen. The red cell chloride content is low. That's because red cells aren't carrying a lot of carbon dioxide and aren't making a lot of bicarbonate. The dissolved CO2 content is low because blood has not yet gone through the tissues where it picks up CO2. And then finally, the amount of carbaminohemoglobin is also low. In the tissues and the veins, you have a lower PO2, a higher PCO2, a higher bicarb because much of that CO2 has been converted into bicarbonate. And then because the CO2 has become higher, the pH has become lower. In the venous system, there's lots of deoxyhemoglobin around. The red cell chloride content is high, as is the dissolved CO2 content, and there's also lots of carbaminohemoglobin. Make sure you understand this table, don't just memorize it. This is the basis of many Step 1 questions asking you about carbon dioxide transport and the changes between the arterial and the venous systems. So now that we've reviewed carbon dioxide physiology, I'll finish this video by going through a couple of special situations where carbon dioxide is important. And the first one is high altitude. So in people who ascend to high altitude, like the top of this mountain here, they are exposed to a lower atmospheric pressure compared to sea level. Because atmospheric pressure is lower, the partial pressure of oxygen is also lower, and therefore, even if they're breathing air normally and their lungs are healthy, they will experience hypoxia, and this will lead to hyperventilation. When patients hyperventilate, that helps to get more oxygen into the body, but it also excretes more carbon dioxide, so the partial pressure of carbon dioxide in the blood falls. This leads to a respiratory alkalosis, meaning that the pH rises. So a normal finding in patients exposed to high altitude is a low arterial concentration of CO2 and a respiratory alkalosis with a high pH. Now initially when patients ascend to high altitude, there's very little change in the bicarbonate level, but after about 1 to 2 days, the kidneys begin to compensate for the respiratory alkalosis by excreting more bicarb. This causes the serum bicarb level to fall, and as a result the pH will go back to normal, although usually it does not completely fall back to the normal range. So shown up here are the key findings of a patient who has been at high altitude for more than a day or two. The pH will be high, the PO2 will be low, the carbon dioxide level will be low from hyperventilation, and if a couple of days have gone by, the bicarb level will be low because of the kidneys compensating for the respiratory alkalosis. Because more carbon dioxide is produced by the muscles during exercise, the carbon dioxide level in the venous blood is going to rise. And I've italicized the word venous here, because if you have healthy lungs, the carbon dioxide and oxygen levels in your arteries should not change with exercise. You should still fully oxygenate your arterial blood, and you should blow off carbon dioxide so that the carbon dioxide level is normal. On the venous side of the system, however, things are totally different. On the venous side, carbon dioxide levels will go up with exercise. In addition, because more oxygen is being consumed by muscles, oxygen levels fall in the venous blood with exercise. So here's a summary slide of the changes with exercise. Your ventilation rate goes up and your blood flow goes up because of an increase in cardiac output and heart rate. Your arterial oxygen and carbon dioxide levels should stay normal despite the metabolic changes, assuming your lungs are working and you increase your ventilatory rate. This means that on the venous side of the vascular system, the oxygen level falls and the CO2 level rises. But on the arterial side, where the blood has just passed through the lungs, the oxygen level will be normal and the CO2 level should be normal. The carbon dioxide content of blood is the major determinant of cerebral blood flow. So let's look at these two graphs on the screen here, which are both classic physiology graphs you can find in many textbooks. On the left graph, we have oxygen content of blood along the x-axis and cerebral blood flow along the y-axis. And what you can see is that throughout the normal range, your oxygen level can go up or down, and it really doesn't have much effect on the cerebral blood flow. The cerebral blood flow is essentially constant even when oxygen goes up and down within the normal range. Only if your oxygen level gets very, very low will you start to see a rise in the cerebral blood flow as the body attempts to make up for that lack of oxygen. Carbon dioxide, on the other hand, has a very different curve. This is shown on the right. Carbon dioxide level is along the x-axis, and once again, cerebral blood flow is along the y-axis. And this is the normal range of CO2 content of blood. And you can see that anytime the CO2 content goes up a little bit, the cerebral blood flow also goes up quite a bit. And so when metabolic activity occurs in the brain, it may change the oxygen content, but that's not going to have much effect on cerebral blood flow. However, metabolic activity is going to increase the CO2 content, and that is what will be the major determinant of cerebral blood flow. And this is very important clinically in patients who have head trauma and other conditions with high intracerebral pressure. What you can do in those patients is hyperventilate them so that the CO2 content goes way down. When that happens, there will be less cerebral blood flow, and that can limit the amount of blood flow into their brain where they have high pressure from intracerebral bleeding. Another clinical application of CO2 and cerebral blood flow has to do with panic attacks. So patients who have panic attacks often hyperventilate, and this leads to a low carbon dioxide content of the blood. This is called hypocapnia, and as we just saw on the last slide, this leads to cerebral vasoconstriction. And for this reason, many patients who have panic attacks develop central nervous system symptoms like dizziness or blurred vision. These are related to less cerebral blood flow caused by the low CO2 level, which is related to the hyperventilation. Our body uses the content of carbon dioxide in the blood to control breathing. The PaCO2 is the major stimulus for breathing. There are central chemoreceptors that are found in the medulla. These are the ones that are most important for sensing the carbon dioxide level. And this is a picture of the medulla here on the screen to remind you of that. There are also peripheral chemoreceptors found in the carotid and aortic bodies. These can sense carbon dioxide, but they're much more sensitive to oxygen. The main chemoreceptors that sense carbon dioxide are found in the medulla. So the way the body responds is if the PaCO2 starts to go up, the medulla will trigger an increase in the respiratory rate that will bring the CO2 level back down. Conversely, if the PaCO2 starts to fall, that will lead to a decrease in respiratory rate. So as you go about your day, you sometimes become more active and produce more carbon dioxide. Other times you may rest and sleep and produce less carbon dioxide. But this is always being sensed by your medulla, and your respiratory rate is being changed in order to match the amount of carbon dioxide and keep the carbon dioxide level within the normal range. There's a high-yield tie-in of carbon dioxide and breathing control that occurs among patients with COPD. These patients have lung disease, and therefore they chronically retain carbon dioxide. If you measure the PaCO2 in a patient who has COPD, it is often above the normal range, and it's always found at that point because their lungs are abnormal. Because the CO2 level is always high, they lose their sensitivity to carbon dioxide that we would normally have. As a result, oxygen becomes the major stimulus for breathing. In other words, they are desensitized to carbon dioxide because the level is always high, and so they begin to sense oxygen and use a high or low oxygen level to determine the rate that the body should be breathing at. What this means is if you give these patients oxygen, because they often are hypoxemic and they need oxygen, but if you give them too much oxygen, this will depress their respiratory rate and they will hypoventilate. And so it's been well known for many years that if you give too much oxygen to a patient with COPD, like this woman on the screen, you can make them hypoventilate and they will start to retain carbon dioxide. Now, I should point out, the theory has always been that the response to carbon dioxide is blunted, and that's why these patients develop respiratory depression with high oxygen. There is newer data that this phenomenon may be more complex than this. There's some evidence that the Haldane effect plays a major role, but the point is still valid that if you have a patient with COPD and you give them too much oxygen, this can cause them to hypoventilate. And so I'll finish with this concept. The carbon dioxide level is always useful to determine a patient's ventilation status. A patient who has a high carbon dioxide level is by definition hypoventilating. If they were not hypoventilating, then the carbon dioxide level would not be high. A patient with a low carbon dioxide level is by definition hyperventilating. If they were not hyperventilating, their carbon dioxide level will be normal. So in the video on ventilation and perfusion, I talk about the determinants of the carbon dioxide level. And one of the major determinants is the ventilation rate of the alveoli. There are other determinants. In other words, your body can produce more carbon dioxide or there can be more dead space. But no matter what happens with those things, if the ventilation rate can match the carbon dioxide level, then the carbon dioxide will stay normal. Anytime you have abnormal carbon dioxide, it always means you have an abnormality of ventilation status. So here's a clinical scenario that you could see on your boards, but you'll definitely see in your clinical rotations. A patient with pneumonia has oxygen applied via nasal cannula. The oxygen level is 95%, so you think that the patient is okay. But when you do an arterial blood gas, the PaCO2 is 60, which is high. This is a very ominous finding. This means that this patient is hypoventilating. Usually this means that the patient has begun to tire out and their respiratory muscles are becoming weak. For that reason, they're hypoventilating. But whatever the cause, you must figure out why they're hypoventilating when this carbon dioxide level is high. Something is wrong, even though the oxygen level is okay. You're maintaining the oxygen level with the oxygen you're giving them, but you're not doing anything to maintain their ventilation rate, and therefore the CO2 level can become abnormal. Here's another clinical scenario, a patient with neuromuscular disease like ALS. The oxygen saturation on supplemental oxygen therapy is 95%. A blood gas is done and the PaCO2 again is 60, which is high. This means the respiratory muscles are failing. And in patients with end-stage ALS, they are often referred for a blood gas, and what their doctor wants to know is the CO2 level starting to climb? If it is, it means that that person's disease is getting so severe that they can't ventilate their lungs. Their doctor is using the carbon dioxide level as an indicator of ventilation status. And sometimes these patients begin to show symptoms of hypercapnia. These can include things like lethargy, confusion, or agitation. If you see anything like this in a patient with muscular disease, you have to wonder if their CO2 level is high. By the same token, if you see something like this in a patient with pneumonia or lung disease, you have to also wonder if their CO2 level is beginning to get high. And that concludes our video on carbon dioxide.